Hello and welcome to Conversations with the Voice of Reason. I'm your host, Benjamin Boyce, and today's conversant is Dr. Rick Bosshardt, who is a plastic surgeon down in Florida. And in this conversation, we talk about his run-in with the DEI push within the medical institutions as well as in the surgical professional organizations. This should be quite troubling stuff to anybody who cares about their physical health as meritocracy erodes and is replaced by Equitocracy. Dr. Rick is a fascinating guy. We get to talk about noses and ears, and we also get into the history of plastic surgery, which I didn't know was hundreds and hundreds of years old. If you're interested in more from Rick, definitely check out my wife's channel. She's got a couple interviews with him, and he's also got plenty of articles out there, links to which will be down there in the description. Without further ado, here is Dr. Rick Bosshardt. How long have you been practicing?
Oh my gosh, depends on what you define as practice. It's been 45 years since I finished medical school, so I've been an MD for 45 years. I've been in actual practice in my current iteration of the plastic surgeon in Lake County, Florida for 35 years.
Okay.
And the rest of the time was largely spent in the Navy, at which time I was a general surgeon.
Okay.
So I'm an old guy. Yeah, I'm one of them.
What was the Navy like for you as a surgeon? Were you just flying around the world saving
Oh my
people?
gosh, I can't say enough good things about it. I have to admit, I didn't go in because of any ultra patriotism, although I always liked the Navy. I like the idea of the Navy, and I'm very proud of my military service. But the practical fact was that I had no way to pay for medical school. And the Navy, all the branches of the military provided scholarships for medical students. And liking the Navy and the ocean as I do, that was the logical branch of service. And they paid for my medical school. I trained in general surgery in the Navy. And of course, all of that led to an obligation to pay back with service, which I did for 4 years before I was able to get back out into the civilian world.
Yeah, for
I
sure.
can't, great memories, made great friends. I think I received excellent training. I would encourage anyone considering medical school that has a problem with how to, do this without going into debt to the tune of $200,000 and $300,000. Military is a great way to go.
Yeah. How much time was your deployment on ships out in the ocean?
I had 1 year. I
Okay.
was a ship's doctor for 1 year, which is a very interesting experience.
Was it?
Yeah, it's truthfully not a whole lot medically speaking. 500 healthy young men, you don't see a
Yeah.
lot.
Yeah.
You do see a number of things that in quantities that you don't see in the civilian world. I won't go into details on that. But we had some
The
wonderful,
rumors of Navy men might be a little true, huh?
oh my goodness, yes. Yeah. But we had a wonderful period of time when we were rescuing Vietnamese boat people that were out in the ocean escaping South Vietnam after we left Vietnam and the North Vietnamese took over. They were hunting down all the South Vietnamese that had helped the Americans, and so a lot of them were leaving in boats by the thousands. And so
Yeah.
we picked up probably a total of 115 refugees. In fact, one of them reached out to me a few years ago when he turned 40 years of age to thank the people on the ship that had taken him and his family on board. And he came across my name in the Navy archives. And of course, he did what anybody would do. He went to Facebook and found me on Facebook and contacted me. We've been friends ever since.
Wow. Yeah, I just ran into the guy who runs the liquor store down the street from us. He was he came across on a boat from Vietnam. He was separated from his family too. He was just a kid. He was like 6 or 7.
There's
And I
some
know,
really incredible untold stories out there that I think at some point in time we need to archive those before we lose them. And maybe, it could produce, I'm sure, a number of books and even maybe some movies, because I've heard some stories that would just curl your hair about things that people have gone through to escape and get to the U.S.
yeah. And it brings into sharp relief the current issues around immigration and asylum seeking that we're looking at right now.
It truly does. It truly does. By the
So
way, I love the name of your show, Conversation. I like that. It means that I can't get too excited. I can't start swearing and spitting. So it's going
If
to
you want
force me
to, I'm
to.
fine with that.
I'll have to behave civilly, which there are people that dispute that I can do that, but and that's another whole story. But I'll do my best.
Oh, really? Are you the doctor with the raging bedside manner? Is that what you're implying?
No, I'm the doctor who is permanently banned for using continuously disrespectful language to my superiors in the organization to which I belong. That's who I am.
Okay.
I'm famous or infamous for my failure to be respectful and for my failure to abide by the rules.
Is this a principled stand, or are you just a bull in a china shop?
Um, no, I've never been much of a bull in a china. I've never been an activist. I've never walked a picket line. I've never joined a protest. Probably the most extreme thing I've ever done is write letters to my congressman to complain about one thing or another. And
Hmm.
yet, at this very late stage of my life and my career, I find myself in the middle of a running battle with an organization that I belonged to for over 30 years that I've always respected and been very proud of, and that has now taken a turn for the illiberal, extreme, and radical
Huh.
politicking and ideology that I was, really disturbed by and pushed back, and they pushed harder.
Yeah. Does this professional organization happen to have an acronym, or did they steer clear of that?
Well, no, it's called, it's the American College of Surgeons, which, everyone abbreviates ACS. So when I say ACS, that's what I'm referring to. That's as close to an acronym as you're going to really get. Um, I don't know how much you want to hear about it.
No,
I
I
know that.
do. One aspect of what I've been covering about just the rapid change in values in our elite has been a lot of that has led me to the professional organizations are spearheading a lot of these questionable decisions around hiring practices, around what values these professional organizations enshrine, which are increasingly more social justice and at the expense of objectivity and meritocracy, from what I've seen. And so, if that's what you've seen as well, I'm totally on board with hearing your experience.
That is absolutely what I am seeing, without a doubt. Something I never ever expected to deal with, especially in the profession of medicine and my own subspecialty of surgery. Um, there are a few places that I can think of in the world where you want merit to count more, and for the striving for excellence should be the most important thing. It's such an obvious thing that I've always taken it for granted, and always assumed that when I sought to become a physician and made that big decision in my life, I tried to get the best education that I could. I happened to go to the University of Miami School of Medicine. U of M is not necessarily the most highly regarded school around, but the School of Medicine, as long as I can remember, has always been very, very highly regarded. And I got an excellent education, and the Navy kind of directed my path in terms of my postgraduate training, but I lucked out and I ended up in a program out in Oakland, California that, looking back, was a superb clinical program to train surgeons. And I came out of it feeling fully qualified to go out and practice surgery. And then finally, when I decided to go into plastic surgery, I thought, well, I'm going to shoot for the best program that I can possibly think of getting into, which happened to be back in Miami, and that was under a surgeon by the name of Dr. Millard, D. Ralph Millard, who was voted one of the top 10 plastic surgeons of the millennium by his own Association of Plastic Surgeons.
How
Um,
long has plastic surgery been around? 1,000
oh my
years
God,
already?
it goes back to the 5th century. As far as an established specialty, it's probably around 1920s.
Okay.
It was one of the early specialties that formally became part of what is known as the American Board of Medical Specialties. That is the organization that provides certification in all specialties. If you want to be a board certified doctor of any specialty, you need to be train in a program that is accredited by the ABMS, which the American Board of Plastic Surgery is one of those. And that goes back to about the late 20s or early 30s when it was first formally recognized. So it's an old specialty. The plastic surgery goes back to the fifth century. I mean, it goes back, it's a really, really old specialty.
The pressing issue of social justice corrupting our society, just aside for just a minute, could you tell me more about the history of plastic surgery? Because in popular imagination, it means like a nip and a tuck. It's cosmetic, but it's much more than that, correct? What is the history of this?
It's probably the most misunderstood specialty of all. That's what people think. They have a idea that it's synonymous with cosmetic surgery. Cosmetic surgery is one aspect of plastic surgery. Then you have the whole other aspect of reconstructive surgery. Yeah. And oh my goodness, when you start to break that down, I mean, if you put cosmetic aside, you have microsurgery, craniofacial surgery, hand surgery, surgery for congenital deformities. Plastic surgery has been in the forefront of things like repairing cleft lips and palates and that sort of thing. All kinds of wound care. Ironically, the very first kidney transplant was performed by a plastic surgeon, believe it or not.
Why? Just because he had particular skills, or?
It was on a set of twins, so the issue of rejection did not come into play. This is before they had the more sophisticated anti-rejection. I wish I could give you names, but I've always been bad on my history and names. But it goes back we still use techniques today that were first used and documented in history back in the 5th century in India. There was a technique of plastic surgery to reconstruct noses that requires moving tissue from the person's forehead down onto the nose, something we call a forehead flap. It's still one of the best and very widely used techniques for rebuilding a nose that has had to been partially or completely removed for cancer, for example. So we're still using techniques that date back to really, really ancient days.
And just on a technical note or etymological note, by plastic, it doesn't mean the substance. It means more like the essence of that word, right? Like that which is molded, that which is moved. Exactly.
The word plastic comes from the Greek plastikos, and that is to have the property of being moldable or bendable. And, with exceptions, a lot of plastics are very, very flexible and able to be molded and shaped. And of course, a lot of what we do involves molding and shaping soft tissue, skin, muscle, and things to create, to replace things that are missing, to correct things that are deformed. And there's even a term plastic. You can use the term plastic as applied to any operation. There are certain characteristics that plastic surgery has that are unique to our specialty. And they may not be unique in the sense that nobody else does them, but it's unique in the sense that we take it to the ultimate extreme. And that is, I watch because I was a general surgeon, so I know what that field is like, and I know what general surgeons are like because I was one. I know that plastic surgeons, by training, are much more gentle in how they handle the tissues and how they dissect tissues and how they do things. We don't use, for example, staples to close incisions. We close incisions by hand using fine sutures, and we make a lot of effort to try to get the best possible scar we can out of it. We try to always have in front of us what my boss, Dr. Millard, used to call the ideal, beautiful, normal. Even if you're doing reconstruction, you have to have a goal. You have to have something you're shooting for. It's not enough to put a blob of tissue, for example, on someone's face to replace a nose. What you have to do is put something that looks like a nose and has all the contours and so forth of the nose. And so there's a lot of planning involved. I mean, I don't know that I can make an incision without drawing a line first. I mean, everything is drawn out and planned. The process is a much more meticulous and delicate process. We are much more critical. I know that I will not accept results that would be perfectly fine to a lot of surgeons because they don't meet the standards that I was trained to aspire to in what I do. So there's a lot of differences that go along, not only in what we do, but how we do it as well.
Yeah, the underlying philosophy, you're working with flesh in a particular way, whereas another surgeon might be more focused on removing a malignancy or solving a problem of which is health related. You guys are more holistic. You're working with the flesh. You understand scar tissuing, contours, and maybe even stresses over time of what any given particular body part's going to be
Well,
useful for and
I
used for.
love the direction tenor of your thing because I love talking about what I do. I mean, I've been doing this for 35 years, and it was the hardest thing I ever had to do to train in this because of the program that I went to. But you're absolutely right. I mean, you have to always maintain an order of priorities. When treating, for example, a skin cancer, it's one thing to pay attention to, removing the cancer and leaving the least deformity possible. But the priority is not to limit the deformity. The priority is to remove the cancer.
Mm-hmm.
And you do what you have to do that. And one of my boss's maxims was, to his referring doctors was, don't worry about the deformity. You take care of the cancer, give the deformity to me, and I'll correct it. I'll fix it. He was very big on principles. Dr. Millard wrote an incredible textbook. I mean, it's I've never seen a textbook like it, called The Principalization. I think he made up the word principalization of plastic surgery. And what he did was every chapter, there were 33 chapters in the book, and every chapter was a principle. Principle could be as simple as diagnose before treating. In other words, if you're going to provide a treatment, you better have a diagnosis that treatment will apply to. And another would have been something like, one of his things was to go for broke. That is, every time you approach an operation, go for the best, most perfect result that you can. If you don't get it, well, at least you tried. But you never shoot and accept something less than that. So there are 33 of these principles that applied. And the thing that was kind of unique about the book was that it was a book that will be as relevant 50 years from now as it was when he wrote it. Because it's not about a specific operation, because operations come and go. But it's about principles behind the things that you do. I can't really say enough about it. I've probably read that book 3 or 4 times.
Yeah.
One of my most valued possessions is a leather-bound copy signed by him that he gave to every one of the people that trained with him.
Wow.
But absolutely, yeah, it's a whole different way of practicing surgery than anything that I've ever seen.
There is a tie-in to the current cultural zeitgeist. When you brought up the idea of the ideal, beautiful, normal, those 3 words are castigated in our elite institutions now as owing to power structures and owing to, they have all these words for it, racism, colonialism, whatever they want to do in order to undermine those terms. But pursuing the ideal, beautiful, normal, applying that goal, which is ideal, so it's not real, it's an ideal, and then the beautiful, again, is subjective, and then the normal is, it's a hazy concept. It kind of is subjective, but it's more of a broadly applied kind of take that we have in our brain. Applying that as a core function of your life's work, I'm trying to think of the question, like what does that mean? What is that goal, that ideal, beautiful, normal? And is that still the goal that is being fostered in students today of your work?
Well, you're right. I mean, you have to be very careful because these days a lot of words are taking on meaning that they were never intended to take. And people start to critique and criticize and categorize you according to certain things. I mean, let's see if I can give you an example. When doing a rhinoplasty, for example, people that come in for rhinoplasty are typically people that have large noses. They have, a big hump on their nose. They have a hook nose. A lot of times they have an ethnic nose. Okay. The people that are from the Middle East have a tendency to have a larger nose than people that from say, Northern Europe. And so the goal for some people is to make that nose look as much like, a Caucasian nose or a Northern European nose as possible. And that's been done. I mean, part of what you do is you seek out the patient's desires. That's one of the goals of plastic surgery. One of the things that not to get off track here because I want to
No,
answer your
please.
question, but
Yeah.
part of social justice comes down to treating people as groups. And treating people as groups is anathema to medicine. Medicine does not treat groups. A doctor treats an individual patient in front of them. So when a patient comes to see me, I try to establish what their goal and desire is. They may tell me this outright, and they come in and say, "I want bigger breasts. I want a smaller nose. I want to get rid of the double chin." So sometimes it's very specific, and sometimes it's just, "I don't like the way I look. I mean, what can you do for me?" Which is a very difficult question to answer because, unlike a lot of surgeons, I don't like to put out my opinion. I tell most people, "You look perfectly fine. Anything you do is based on what you're trying to accomplish." But back to what I was saying, one of the things that has happened in plastic surgery, and going back to the example of the rhinoplasty, is that we've gone from techniques and surgeries that essentially produce a very, very consistent product, which is this little bob nose that you can always tell someone had a nose job. I mean, it's just pretty obvious because they often don't look natural. And they've gone from that to trying to produce a nose that is ethnically authentic. So if you get a person from an Arab country or you get a black person that has the nose that is commonly seen, that is somewhat thick, has thick skin, and they come in trying to see if they can improve their appearance, you're not going to try to turn that nose into, gosh, the poster boy for this is Michael Jackson. I mean, his nose went through multiple surgeries to produce something that looks so bizarre and out of any match to his face. But you try to produce something that's going to be aesthetic improvement based on your conversation with the patient, but yet will be, ethically and racially and so forth congruent with that individual.
Yeah.
That's the goal. Cosmetic surgery is defined by the fact that you're taking something that is basically considered normal. It may not be pretty. I mean, the person's nose may not be pretty, and their breasts may be saggy, but they're normal. No one would say you're disfigured or deformed, and you're trying to make it better than normal. And that's the goal of cosmetic surgery, is to supersede the normal. In reconstruction, you're taking something which has been deformed or damaged by accident, by surgery, by bad genetics, and you're trying to restore that to normal. So that's where you have to have some idea of what you're shooting for. If you don't have that, then you're kind of walking blindly. I don't know if you've heard of the golden proportion or the golden ratio. Had that ever come up in any conversation you've ever had?
I geeked out on that.
Okay. Well, that's something which is, that exists throughout nature. If it's very consistent. It's a ratio that you find all through nature. Butterfly wings have it. If you look at something like the Parthenon in Athens, Greece, the Parthenon is constructed so that all over the Parthenon there are things that are in a golden ratio. And a beautiful face that most people would agree is a beautiful, attractive face is going to have golden proportions. We don't use them practically, but they're there, and we unconsciously see them.
Yeah.
So when you see someone, you say, "Oh, that's an attractive individual." A lot of times, what you're doing is you're processing in your head an image that is based on expectations that may have developed over the course of a lifetime from culture and society and this and that.
Yeah.
And that's fungible. It doesn't stay the same all the time. So it's an interesting profession because I call it the surgery of identity. You want to make sure that when you do something on somebody that you don't so disturb their identity that you make them unrecognizable, particularly to themselves. I mean, there are people that are crippled by bad plastic surgery and even by good plastic surgery that didn't produce the result that they were expecting.
Yeah. Just as an aside, a long time ago, I was working at a Starbucks and it was a really busy day and I was kind of just tripping out because I was getting exhausted. And I was walking around the cafe, cleaning up after everybody. And for some reason, I thought, what if there were just noses. And my brain just started filtering out everything except for noses. And I just watched all the different people's noses, and there were so many different shapes, and they're all kind of weird because noses are just weird. They're weird things. So I'm finally talking to somebody who spent years considering the nose. And I'm wondering if you have any nose facts for me. Because I know, like, just like off the top of my head, like, there's a reason why, let's say, people from the Middle East have that kind of nose, because they're in arid climates, and right, the nasal cavity, and then there's probably a relationship between the nasal cavity and the cheekbones and the forehead. You've probably considered all these things from an ethnic point of view, and the ethnic differences are owing to adaptations to the environment.
I'm going to disappoint you.
Oh, okay. You don't have any nose facts?
I I know exactly what you're saying because it's an occupational hazard. I can't walk out there in the public, out in public and look at people and not be trying to break down what I'm looking at. Why did that person catch my eye? Even when I'm doing other things on a patient, for example, I will often look at the nose and say, is that a good nose? And I'll start breaking the nose down. Okay. Is that a nice slope to the top of the nose? Is the tip of the nose not too pointy? It's not too low, not too high? Are the nostrils a proper oval? Are they not too big? So we're constantly assessing and reassessing. What's interesting is that you can walk in a crowd of people and you will immediately you won't give most people a second look because they look normal, normal. They meet all the criteria in your mind that you define as a normal appearance. But you get that one person who has this huge honker of a nose, and that jumps out at you because it doesn't fit. There's not a balanced look to that. And unfortunately, some people think that everybody needs to be beautiful and have perfect features, but there are many people that you identify with because their features are not normal. You take a Barbara Streisand, you give her a nose job, and you've destroyed her face. I mean, you truly have. You take a Jimmy Durante and you give him a nose job, and you've ruined an iconic individual appearance. So you got to be careful sometimes that you don't try to do too much. I talk a lot of people out of surgery. I see people come in, especially as I've gotten older and more conservative. I see people all the time. I look at them and say, you need to think about this because, what you're asking for, sure, it can be done. But sometimes you have to ask the other question, should it be done? And I will tell some people, you are foolish. I've said that a number of times. You have some medical issues. This is not a medically necessary operation. You've lived your life this way. You're married. Your husband or your wife loves you. Your kids and your grandkids are delighted with you. Why would you want to do something now that carries a surgical risk, carries no guarantees? There's not a plastic surgeon, or for that matter, a surgeon alive, who's going to guarantee a patient a specific outcome. I mean, anyone doing that is a fool, and you probably should run from that type of a physician. But it's one of those things where we're not the magic bullet for people's problems. I think that it's an extension of wanting to look your best, which is a natural human trait. It's a natural thing for people to want to blend in within their culture. So, someone is, and the people that don't do it stand out because they're the outliers. They're the goths and the people that are heavily tattooed and pierced and this and that. But for most people, they're going to comb their hair, they're going to shave, they're going to trim their beard, they're going to take some time to pick an outfit of clothing that's going to look reasonably matched and current with respect to the fashions of the day. And they're going to go out there, wanting to put their best foot forward. Plastic surgery is an extension of that. It's just a little bit more extreme example. But it can be carried to an extreme where it becomes a fixation or an obsession or that sort of thing. And part of my role is to try to weed those people out because you do not want to be operating on people that have expectations that are from the very get-go are not going to be met or not realistic at all.
Yeah. There is a popular writer, Mary Harrington. She's a British writer. She just does a lot of op-eds, but she's a wonderful writer. And she has been critiquing the the excessive amounts of stress that people are putting on so-called gender transition, and how the idea that there's such a thing as the idea of the trans person or the trans kid specifically is owing to a conception of ourselves that she calls the meat Legos, that people are starting to think of ourselves as just, we can swap out these body parts, and there's nothing essential to how we function other than like what our will wants to function. That's an extreme example, but I'm wondering if you can chart, or you already made a line in the sand between reconstructive and cosmetic surgeries, and those are two different ethical rubrics that you apply to a cosmetic surgery as opposed to a reconstructive surgery. I'm just wondering, how have you manicured or maintained a healthy ethic with regard to modifying body modification, non-necessary body modification, and where do you see it heading with technology is and just human desire to look the best or look what they want to look like?
My best answer for that is going to be that when I was contemplating plastic surgery, when I was first exposed to it, I was as a medical student. It was just for 2 weeks. I did a 2-week rotation on plastic surgery. And at that point in your career, you know so little, and you're so focused on getting through and successfully, completing your education, getting your MD degree, that I don't think you have the ability to really understand everything about it. I did rotation in plastic surgery as a general surgery resident for a couple of months with a plastic surgeon in the Naval Hospital. And that cemented for me a fascination, because I concluded that what I was doing as a general surgeon was life-saving. We saved lives. We cured cancer. We removed ruptured appendices. We took care of trauma patients. So it was life-saving. But it produced, a lot of times you produce a very significant deformity. When you cut off a breast for cancer, that's a pretty disfiguring thing to do. And then I came to plastic surgery and realized that unlike what I was doing, which was life-saving, plastic surgery was life-changing. And I like that. That just spoke to me. And that's when I came to that realization, that's when I concluded. So as I was contemplating going into plastic surgery, I had to deal with the question that you've asked: what about cosmetic surgery? Because a lot of my peers felt that I was really turning my back on real surgery, that I was doing something which was now trivial. It was the domain of the well-to-do and the vain people and so forth. And so I posed this question to my boss, Dr. Millard. Dr. Millard had one of the busiest, biggest cosmetic practices you could possibly have. This is in the day before the internet, before there was even advertising. Doctors couldn't advertise back then. And yet he had a more than 2-year waiting list of people to have cosmetic surgery with him. And I asked him how he reconciled all the training we went through in doing cosmetic surgery. And his answer has stuck with me. He said, "Rick, if you can't take something normal and make it better than normal, you will never be as good as you can be at taking something abnormal and making it normal." Mm-hmm. And so a lot of the skills and the thinking and the planning that we apply to our cosmetic surgery translates directly into skills that we can use in the area of reconstruction. And you have to be careful. Like I said, there is a healthy desire to improve yourself. If someone comes in and they're 60 years old and they look 75, and they tell you, I feel great, I look great, but everyone looks at me and thinks I'm old. The desire to have your appearance more in balance with, the way you think and feel about yourself, I don't think that's unreasonable. I don't think that's outrageous or excessive. You get a young lady comes in that has, and I've seen this many, many times, literally has no breasts. I mean, she comes in and she's got a chest like a boy, but she's, obviously a girl. We won't go into the whole gender thing at the moment, but you look at her and you say, my God, in any normal situation, this would be considered a reconstructive situation, not cosmetic, but insurance will never cover that.
Okay.
I've done patients where they had one breast that developed and one breast didn't. You get some girls that have attractive breasts that just want to be fuller, and I can do that for them. Is that right or wrong to do? I guess there are people that would say that we shouldn't be doing that. Other people say go for it. Is this? I think it comes down to the fact that I'm not trying to sell my services. I have never tried to talk anybody into cosmetic surgery. If anything, I do the opposite because the longest part of any consultation that I make with my patients is in covering the complications and making sure they understand the limitations and the complications that can arise from what they're contemplating doing. Once I've done that and I inform them, and I think that what they're asking for is reasonable, I'm happy to do that. There was also an interesting. Do you remember the movie Doc Hollywood with uh, Michael J. Fox? Where
No, I,
he was on his way to a plastic surgery training program in California and got waylaid because his car had a mechanical or something in a little town in Georgia where he was stuck for a while. And he grew to love the townspeople. And ultimately, he came back to that and became a town doctor. But that was based on a book, and I met the author. And one of the things that came out of that was when he was explaining about why do cosmetic surgery, he was saying, well, that's because the income that I derive from doing cosmetic surgery frees me to be doing, reconstructive surgery on people that can't afford it. So it was this altruistic idea. Okay, that's fine. But if you look at the way most plastic surgeons practice, they're not doing that. How many free operations do you have to do to compensate for doing a ton of cosmetic surgery? I've done mission trips numerous times overseas to provide reconstructive surgery, not cosmetic, reconstructive surgery on indigent children and individuals. It's one of the most wonderful things I've ever done. But I don't claim that, I do cosmetic surgery because it provides me the income to do that. I do that just because I think it's a responsibility I have to do that. But some people will say cosmetic surgery is a way to pay for the reconstruction that doesn't pay very well. And it really, truly does not pay very well.
really? Why? Because it's not necessary, and
I
usually
have
it's
a
just
theory.
people don't have, yeah.
I have a theory. Number one, it's not going to save someone's life for example, to build a breast. If a person has a skin cancer and you take it off and you produce a disfiguring scar, they can live with the scar. I mean, you can go about a perfectly normal life with a scar. So I think that whether it's a conscious or unconscious decision, I think that a lot of insurance companies not insurance companies necessarily, but it's the groups that value surgeries. There are books that provide a value for different operations so that you know what you should be charging for the work that you do. They terribly undervalue reconstruction. I mean, what I get paid by Medicare for doing hours and hours of a reconstructive procedure versus what I can derive from an hour of a cosmetic surgery. The discrepancy is just unbelievable.
Yeah.
And they overpay for small stuff. They'll pay me well for a skin cancer. They'll pay me terribly for a 5, 6, 7 hour microsurgical procedure, to transfer tissue from one place to another. So yeah, it's very undervalued. Most surgeons cannot practice independently solely on reconstruction. Most plastic surgeons are going to do some cosmetics. When someone is doing sole reconstruction, they're almost always employed by a major corporation or major hospital medical center that pays them a salary, probably accepts the loss in order to be able to provide for that service. But the pay for the procedures by insurance companies is really bad.
And this is an odd question. I was just thinking about that. You're just making me think about the body and stuff. So what is your kind of domain? I guess bones and skin? Like, what are your like 3 favorite organs that are most used or most manipulated aspects of the body?
I'm a soft tissue guy.
Okay.
I've always worked primarily in soft tissue, that's skin and fat and muscle. I've done my share of bone work. I've done bone grafts. I've taken care of, I do hand surgery because that's part of the training of a plastic surgeon. So I've treated, complicated hand fractures and finger fractures and things like that. I've always felt more in my comfort zone in soft tissue. One of the people I trained with was perhaps one of the top two craniofacial surgeons in the world. He was trained by the father of craniofacial surgery, and he just passed away very recently. His name was S. Anthony Wolf. We used to call him Tony Wolf. And Tony Wolf would do the most incredible reconstructions on the faces of children that involve cutting the bones, moving the eye socket around, moving the skull around, pulling the jaw out, pushing the lower jaw in. I mean, when you watch these things being done and you imagine this is what I'm training to do, it's almost mind-blowing. Most people that do that go beyond my training. I trained in plastic surgery for two full years. I could have gone on and done a fellowship in that kind of work. It wasn't my interest. I didn't, because that you have to do in a major medical center. You can't do that in a place like I practice, which is a community hospital in the middle of Florida. But there are people that do bone work that is just beyond belief. And he was one of those that just was second nature to him to do bone grafts and that sort of thing. For me, soft tissue is the way to go.
When you're thinking about working on the skulls of children, to what degree is he taking into account how that skull's going to grow? If he tells it what to do at a certain stage, it'll keep on like a bowling ball. It'll just go in the direction, or
Absolutely. You have to, in children, you have to take growth into account. And if you don't, you shouldn't be doing what you're doing. Sometimes what he's doing is actually freeing up a skull so that the brain can grow and the child can grow. Sometimes it's adjusting things so that an eye socket that's too shallow, where the child can't close their eyes and they risk blindness because their eyes dry out. You have to deepen that eye socket. So your factor, and when you're doing anything on the jaws, for example, doing work on a cleft palate, you don't want to do these too early in life because you will affect the growth of the palate. Ear surgery, the ear is nearly 80 to 90% grown to its adult size by the time you're 6 or 7 years old. And so when you get a child that has one of these really bad, bat wing ears, you want to catch them before it becomes something that they're teased about and become self-conscious of. But you don't want to do it too early where you'll affect growth of the ear. So the ideal timing most of the time is right around when they're about to start first grade or, late kindergarten, first grade. So you have to take into account their growth and development. Absolutely.
Wow. Have you worked much with ears?
I've done my share. Yeah, I've done, you see a lot of ear cancers. So you're cutting off a big part of an ear and you have to rebuild that. You were saying a nose is interesting. Ears are fascinating because they're extremely complex. And like a nose, there's not a lot there to work with. You have some skin and some cartilage.
Yeah.
And not a whole lot more. And then you have all these very complex curves and things that you have to try to recreate if you want to produce something. The nice thing is people don't look at your ears at the same time unless you're looking at somebody dead on and comparing the two ears.
Yeah.
As long as each ear looks normal, you can have one ear that's maybe even half the size of the other, and it won't be terribly noticeable to people unless they actually consciously are looking for a difference.
Wow. Just so many things I haven't really thought of, but designing an ear from scratch, do you transplant cartilage or do you use like some sort of other substance for
I'm a dinosaur. I trained in 1987 through 89, and back then, the way we would rebuild an ear, there were, procedures that were designed by some brilliant reconstructive surgeons that involved taking cartilage from the ribs. And you could actually take a piece of cartilage from part of the rib, and then you would sit there on the back table and you'd carve the contours of an ear. And then, of course, you would implant that and have to cover it with skin. And that would require usually a multi-stage process. Today, I can't speak to the current status of this because I really haven't kept up with things that I don't really deal with on a day-to-day basis. But I know that they're working on growing organs now.
Yeah.
So they're doing tissue culture and they'll take, tissue from a person, they'll grow an ear on a petri dish, and you get it to a point where you can actually transplant it. And if it's done with the individual's own cells, you're not going to have the issue of rejection to have to contend with. So there's a lot of advances. I don't know if that's reached a point where it's standard of care at this point in time.
Yeah.
But there are some incredibly good ear reconstructions that were being done even 30 plus years ago.
Yeah. So we began by taking a shot across the bow of your professional organization. When did the industry start changing on you on that level? And when did you start speaking up and why?
I started speaking up. This is a very gradual evolution, mind you, but I started speaking up first around 2019. And that was based on something that I read. Just to give you a quick, or your listeners or viewers, I should say, quick background. The ACS, the American College of Surgeons, is the oldest, largest organization in the world that represents surgeons of all specialties. And the focus of the ACS has always been excellence. It's always been to provide the means to support surgeons to be the best they can be and to provide the best care for patients. And it's kind of an honorary thing to be a fellow of the ACS. There's a selection process that you go through. And I was selected back in 1991 after I completed my plastic surgery training, was very proud to put that FACS after my MD, and went on with my practice through the years. I had very little active engagement in the ACS beyond, getting their journal and the bulletin and things like that. And then in 2018, I came across a bulletin issue that had the text of a speech given at the Clinical Congress, which they hold annually. It's their big annual meeting. This was done by a pediatrician who is the director of diversity and community partnership at Harvard. And her speech was titled "A Path Towards Diversity, Inclusion, and Excellence." That was the title of her talk. And I thought, that's an interesting topic. And I read the text, and I read it through twice. And it was all about diversity. There was nothing in it about excellence. Excellence wasn't even, the word didn't even appear in the text of that article. As a consequence, I sat down and I read a long commentary. It was probably a full single-space page. And that was actually printed in the Bulletin of the American College of Surgeons, along with the other 3 commentaries that were submitted. And each of them was maybe a sentence or 2. Nothing happened. I mean, it was printed. I never got a single bit of feedback on that from any.
What was the content of this response?
It was basically my concern that we were taking excellence and subordinating it to diversity. And I felt that was a mistake. I thought that we need to maintain the emphasis on excellence and not to be looking at diversity as the prime motivator for how we practice and what we do. And so nothing happened, and that stimulated me to start learning more about things like social justice and the whole industry of diversity, equity, inclusion that was just now beginning to come into its own. And this was through 2019. And what happened was in 2020, of course, we had the George Floyd killing and the riots, and the country went crazy, went literally crazy. And there was this stampede. I mean, every institution in America could not jump on the bandwagon fast enough to declare themselves, aligned with Black Lives Matter and an agreement with the idea that America was a systemically racist country, and so forth. And the ACS did the same. So what they did is they assembled a task force on racism. This was done within weeks. I mean, George Floyd was killed in May. In June, this task force was assembled to study. And this is where it got interesting. When you read the bulletin, it says to deal with the issue of the problem of systemic or structural racism in the ACS. It was not whether or not there was racism in the ACS. That was a given. The ACS was structurally racist, and we had to form this task force and provide these recommendations to deal with that racism. And so the recommendations came out, and it was just a laundry list of anything you can think of that had to do with the DEI, anti-racism, white supremacy, white privilege, you name it. The basic thing that most struck me and I most objected to was the allegation that, number one, the ACS was systemically racist. Number two, that the surgeons in the ACS were racist and couldn't help it. And of course, we're talking mostly about white surgeons. And three, and this was really where they went off the rails, was that surgery itself was discriminatory, that the practice of surgery by its very nature was discriminatory. So what did they have to base this on? There was no evidence. They didn't provide a study. The basis basically was disparities. And that's what it always comes down to is if you have disparities, that is, you don't have proportional representation of minorities in a certain situation, then that situation is a racist situation. You kind of wonder how the NBA and the NFL escape that, but they somehow do. But because there weren't 14% black surgeons in the ACS, then the ACS was racist. And the other thing was that, it's pretty much accepted that if you do studies, you'll learn that minorities in certain groups, blacks and so forth, when you look at the outcomes from surgery, that they don't do as well from a lot of different surgical procedures and so forth. And so, of course, that's because of racism. That's because they don't get the care from their surgeons that they would. And I've even heard the leadership of the ACS specifically state that it might be that it's better for a black patient to have a black surgeon because they'll get better care. So, I mean, these things to me were so completely wrong. I mean, that was so defamatory and so toxic. I couldn't not respond. So I sent a letter to the president of the ACS at that time, wrote a long letter. I happen to love writing. That's what I love to do and kind of what I plan to do more and more in my retirement. But I wrote a long letter in which I kind of listed my concern. I gave my background. I'm half Brazilian. I was born and raised in two cultures. I have my parents were never, ever racially discriminatory. My mother, a Brazilian, came to Miami, Florida during segregation when there were separate facilities, public restrooms and water fountains for blacks and whites. And she always made it a point to use the black facilities. She always went to the black restrooms and used the black water fountains. She refused to bow to this segregation. So anyway, so I was really incensed about this, and I told them, I said, to call our organization, which is so respected and done such an incredible job of helping surgery to evolve to be as good as it can be, to call it racist, and to call us racist, and to call surgery racist, I can't accept that. And if we don't change this direction that the ACS is clearly going in, I'm going to drop my fellowship. I couldn't think of any other threat that I could offer that had any consequence. So I said, I'm going to drop my fellowship. I got no answer from that. That letter never got an acknowledgement or a response. And so my next step was to say, well, that didn't work out too well. Maybe what I need to do is go to the actual membership of the ACS and try to go that route. So what I did is I went to what's called the communities. The communities is a discussion forum on the ACS website, and doctors can post questions in clinical situations. They can initiate discussions and network back and forth. And so I went on the General Surgery Forum, which is the largest forum of the many in the ACS, and I posted I put a post up, and it basically said the same thing I said in my letter. I said, I cannot countenance this claim that, this is a racist institution, that I'm a racist, that surgeon, and so forth. And if this doesn't stop, if this direction does not change, I will drop my fellowship. And that particular comment generated a comment thread that ran for 4 months. Almost broke the system. They had to actually go to a second thread because there was so much engagement there that it was slowing the system down. And more engagement than any other in the history of the ACS. 2/3 of the people that commented on that thread agreed with me. They agreed that there was concern here, the reason for concern. I was asking for several simple things. I asked for an acknowledgement that they were actually doing what they clearly were doing. I said, are you embracing, DEI, critical race theory, which DEI basically euphemism for critical race theory? Are you embracing that? What is the justification for calling the ACS and surgeons racist? Give us your evidence. Show us where the problems are so we can deal with them. And never got anything from the leadership that remotely addressed those questions. Well, that thread ran its course. It like a lot of threads do, eventually it dies down. People, there's only so much you can comment. So I kind of backed away from it and was thinking about what my next step would be. And I really hadn't thought about it in any kind of depth. And what happened was the leadership approached me. Oh, one thing I should mention that's really interesting. I got a kick out of this because it was so clearly gaslighting. The ACS hosted a leadership retreat for all the leaders of surgical societies in June of 2021. And they invited a keynote speaker. The keynote speaker was Ibram X. Kendi. Kendi wrote the book, How to Be an Anti-Racist. And he's the one that proposes, discrimination is the answer to, reverse discrimination is the answer to discrimination. And he's proposed a Department of Anti-Racism in the U.S. government that's going to oversee all other departments to vet them for their compliance with his anti-racism. It's just unbelievable what this guy believes in what he's trying to do. So, here they invite the most vocal, visible advocate of anti-racism and DEI and critical race theory to their leadership retreat as their keynote speaker. And I and others said, well, why don't you invite some other people? There are so many Black intellectuals that you can invite that will provide an alternate view to Kendi's. Shelby Steele, Glenn Lowry, Ian Rowe, Thomas Sowell. I could go on and on. I know all these names now because I've been dealing with them and reading about them for several years. Yeah. And no, the answer was no. So anyway, the thread runs its course. I don't know what to do. And I get approached by the leadership of the ACS. Now, the ACS has 84,000 surgeons. I'm one little guy in Lake County, Florida. Okay, yeah. What influence do I have? But I guess I made enough noise that it caught the attention of the leadership. And so they approached me and said, we'd like to do a Zoom call with you and discuss these concerns that you've expressed. I said, great, let's do it. So we did. We had a Zoom call in March of 2022. And at the Zoom call were 5 people, 3 from the ACS, myself, and a colleague of mine. There was one of the Board of Regents. There was the General Secretary of the ACS, and their newly installed Director of Diversity, which is a whole new department that they had installed based on the task force recommendations. And the colleague that I invited was a local surgeon that I worked with closely. He was a good friend. And I liked it because she checked all the right boxes. She was female, she was Black, and she was totally against all these things that were being done and had supported me throughout this comment thread. We had a lovely discussion. Everyone spoke there, was very civil, professional. Everyone expressed their opinion about the issue. Nothing was agreed upon. No consensus was reached, but it was very encouraging. I sent a long email of thank you to all the people, especially the ACS people that participated, that I hope this will be the beginning of an ongoing dialogue so we can discuss this controversial issue within the ACS, bring in the membership to talk about this. And within a couple of weeks of that Zoom meeting, this was now in April of 2022, I discovered that I could no longer access the communities on the website. I would try to get into them, and I couldn't. I was blocked. I thought at first it was a glitch in the system, and I tried for a couple of weeks unsuccessfully. Finally went to the Secretary General, the General Secretary of the ACS, a surgeon named Tyler Hughes, who is now the elected Vice President. and said, Tyler, I can't get on the communities. What's going on? And this is when they first told me. This was the first inkling I had. Oh, you've been permanently blocked. You're permanently banned from access to the communities.
Why?
Took me a moment to let that sink in. And I said, well, why? Said it's because you have been continuously using disrespectful language in your comments, and you continually post non-clinical material on the clinical discussion forums. And what had happened is that he had changed the rules between the Zoom call and my telephone call and my ban. They changed the rules in the communities to prohibit any non-clinical discussion in the clinical forums, which is where I had placed my comment was in the general surgery forum. Well, what's really interesting and kind of hypocritical about that is that one of the big reasons for pushing all these new initiatives in the ACS is the disparities in clinical outcomes. I mean, they're telling us that blacks don't do as well from surgery because of racism in surgery. And so how in the world do they say this is not a clinical discussion? Well, that was the reason he gave. I said, give me an example. I said, show me an example of something I said that was disrespectful, or show me an example of one of my comments that was inappropriate. And they never have. From that day on, they've never shown me a single thing. The other interesting fact is that not only did they block me from access to the community, so I can't communicate with the surgeons in the ACS, I'm blocked from access to the members directory. I can't even look up a surgeon's email address or anything on the ACS website. So it really isolated me. And then they blocked me from my private mail. I have a private mailbox. And I was getting a lot of support in that mailbox from surgeons that said, I agree with you, keep going. I can't speak up publicly because it would risk my career. The idea that a surgeon would be scared to speak up blows my mind, because surgeons are not shrinking violets. We're pretty confident, forceful individuals that don't like to get pushed around.
Wow.
So the ban went into effect. I appealed to the Board of Regents. That was denied. They told me I received due process in this decision. So that was a flat out lie, a total lie, because I went to the head of the Central Judiciary Committee. This is a department in the American College of Surgeons whose sole job is to deal with disciplinary matters. Okay, if you're a member of the ACS and you're misbehaving in some manner, you'll be called on the carpet before the Judiciary Committee, and they're going to investigate the allegations or the accusations against you. And they will decide if they are, legitimate. And if they are, they will propose a punishment of some sort. And then they will send that to the Board of Regents, who then informs you that you are being punished. Well, there's a protocol for this, and this is very clearly spelled out in the bylaws of the ACS. You're supposed to be informed that you are being considered for some disciplinary action. I was never informed. You are supposed to be given the opportunity to provide a defense. In other words, you're allowed to have a hearing before the committee or the board to hear what the accusations are. I mean, to be told that you've been accused of something and not be told exactly what it was doesn't sound like due process to me. And so they hadn't done that. And then the third thing is, before any punishment is put into place, you are to be informed that this is going to happen. None of that occurred. So I requested a hearing. I said, I want a hearing. I'm a member in good standing. I still am, by the way. I have not been kicked out of the ACS. And I went to the head of the Judiciary Committee, said, I want a formal hearing. And this is where things take a turn for the surreal. This is where they really get crazy. So he tells me that my ban was never discussed by that committee. The committee that's in charge of disciplining members of the ACS never heard about my ban, never was involved in any way, shape, or form in that ban. And because of that, my lifetime ban, and I repeat, this is a lifetime ban, is not a disciplinary matter. And therefore, I don't get a hearing. I don't deserve or rate a hearing.
Oh.
Yeah.
Wait, a punishment isn't disciplinary. What is it then? Is it not a punishment?
Well, you're asking the obvious question, and I've been asking that question for the better part of a year and a half, and I have yet to get an answer to it.
Huh.
So this is kind of why we're talking today, Ben. This whole thing came about through no conscious intent of mine. I didn't go out to become this agitating activist against the ACS. I still want the organization to thrive and to do well and support surgeons and actually fulfill its mission. The mission of the ACS is to heal all with skill and fidelity. That's the mission statement of the ACS, pretty much all encompassing. And I'm not trying to bring anything down. I have to confess, I'd be happy to see a complete turnover in the leadership of the ACS at this point in time. But I went public. During the course of all this, I joined a couple of organizations, fantastic organizations. I can't recommend supporting them enough. The first one was FAIR, the Foundation Against Intolerance and Racism. And I'm a founding fellow of FAIR in Medicine, which is kind of a medical offshoot of FAIR, which is fighting against illiberal things like critical race theory and DEI and things of that sort. And the second one, I don't recall how I came across them, but Do No Harm, relatively new organization, Do No Harm medicine.org. They only opened, their organization was launched in March of 2022, I believe it was, or April, thereabouts. They're not even hardly 2 years old. And tremendously effective in pushing back against things like colleges requiring that applicants submit DEI statements and offering scholarships that are not open to whites, only open to blacks. And they've been pushing and pushing and pushing for eliminating race-conscious selections, trying to encourage meritocracy, a return to things that should be obvious, that you want the best possible people in medicine, you want the best candidates for medical schools, you want the best medical school graduates for the best programs and training and so forth. And so these two organizations have been so incredibly helpful. And by virtue of my affiliation with them, I've been able to get a lot more exposure than I ever imagined in my wildest dreams. I've actually had an article published in the Wall Street Journal back in September of 2022. In 2023, I had articles posted twice in the National Review, one article in City Journal, and just a week or so ago, I had an article published that was over the holiday. I had an article in the Washington Examiner, which all pretty much are regarding this situation of mine. I don't know if I'm talking too long. If you have questions, please stop.
So what is the downstream effects of these policies? I mean, they are disabusing you of just respectful, just treating you with basic respect because you're violating their ethical code or something, or they're trying to keep this stuff from being criticized, which is, okay, that's one conversation, one topic. But what happens? What's the downstream effects of these DEI policies in hiring, in training, and then in application in the medical field? And are we seeing those effects yet?
That's a $64,000 question. And that's super important because while my ban is an indicator of the radical transformation of the ACS, I mean, the idea of banning civil discussion and debate and so forth in a professional organization, that should never happen. But the other problem is this: when you start putting diversity at the head of the line, if your goal is to have proportionate representation of surgeons, which is one of the thing that has been the biggest push, of the fact that we don't have enough black surgeons in the ACS. Okay, so we have a 14% population of blacks in the American population, and there's only 2% blacks in the ACS. So what do we do about that? Well, the problem is this: if you start to raise diversity up to the primary goal of, say, the organization, then you've got to find a way to raise those numbers. If those numbers aren't there, if there are not enough qualified applicants for medical school and surgical residencies, then the only thing that you can do is to lower your standards to the point where you do have more people qualifying, because they're not qualifying at this level, so they got to bring it down. And this has not just happened in the ACS. This has happened. We heard about this all in the universities because, they have quotas for blacks. They have quotas for Asians. I mean, it's crazy. I mean, it's just, you got this crazy system that categorizes people into identity groups, and based on the group that you're in, you're either favored or not favored. Okay.
Yeah.
The least favored group is me, the old white male, basically. But you're not going to be able to have merit and excellence as primary if you put diversity first. They're incompatible. You just can't do that. We've already eliminated things in medical education that are making it very difficult to establish who are the best students and who are the best performers. They don't have grading on the medical college aptitude test. So today you can get into very, very elite competitive medical schools based on an essay, based on your lived experience. You can have a medical college aptitude grade that is 2 standard levels below the average applicant, and you'll get in based on meeting the right boxes, if you're black or Hispanic or some such thing.
Have the insurance companies done the math on this with regard to malpractice insurance and how much they're going to have to be covered, or are they going to lower the standards or raise the standards of what it means to have a malpractice suit?
That's probably going to happen, but I'll tell you right now, they're just as captured as everybody else is. I mean,
the insurance,
these corporations and everybody out there, I guarantee you, every insurance company has got a department of DEI in that insurance company. That's
but they still have to count the beans. I mean, you can't. The beans are the beans.
Well, it's starting to happen. I think I think the tide is turning. I mean, I think that the whole debacle of the 3 university presidents before Congress was kind of an eye-opener for many, many people about how far this has gone and how bad this can be. I mean, it's going to happen. I mean, you're going to find, I have contacts among young surgeons who are in training that tell me things that will curl your hair. That, and I know, and this is not anything new, it's just that I never heard it firsthand like this. I know that many of my colleagues that have been out there for a long time, like I have, that trained before all these social justice and other ideologies came to be. We look around and we see the crop of young surgeons coming out, and they're not qualified. I mean, it is common. It is not at all unusual to have a surgeon come out of a residency fully trained, completed the residency, qualifies to sit for board certification, and yet they're not ready to operate independently. And they show up in a hospital, and pretty soon you find that they have to be mentored for 6 months or a year or more by an experienced surgeon, kind of holding their hand in a sense until they've demonstrated their capability to practice independently. That's crazy.
So it's burdening an already burdened system, right?
Oh, absolutely. Absolutely. I mean, you were already short surgeons as it is, and to have surgeons coming out of training programs that aren't qualified to practice until they've had further, post residency training, that's never happened before. I mean, it was most people are eliminated in their 2nd or 3rd year of residency if they can't cut it as a surgeon. I mean, we're being monitored every year. We're being given more responsibility and seeing how we respond to it. And, you have senior surgeons that operate with you and see how you work. By the time you're in your last year of training, they pretty much cut you loose. I mean, they know your capability. They expect you to ask for help if you need it, and they're letting you train younger surgeons, letting you, supervise younger surgeons doing their first appendectomy or gallbladder surgery. And so that's the way it was when I was in training. Today, that's not the case. I've had surgeons tell me that, they never did certain operations that are basic surgeries in the field, that they've never done a single one in the residency. Yeah. I had one young surgeon that was doing a case dealing with a breast cancer. And in the middle of the operation, he told me, I'm really glad that we don't have to go after any lymph nodes in her armpit because I've never done that before. I'm thinking, how the heck do you finish 5 or 6 years of general surgery training and never learn how to remove lymph nodes from someone's armpit? That's a basic operation in a lot of cancer surgeries. So yeah, we're seeing a what I believe is a very real degradation in the quality of surgeons out there in surgery. Now, I have to be careful because, people say, oh, it can't be that bad or people will be dying right and left. Well, that's absolutely true. For one thing, the human body is amazingly capable of,
Can it
of surviving.
survive DEI?
It can survive a lot. Okay. But there are excellent surgeons. I would be
Yeah.
remiss if I didn't say that there are programs that are doing their job. I have a daughter and a son-in-law who are both physicians. And my son-in-law is a pediatric orthopedic surgeon. And I see the work he does, and I am blown away. I mean, he is clearly a brilliant surgeon, very, very good at what he does, although he's very young and just out of his training and already assuming a lot of responsibility in a major medical center. So there are those people, but there are way too many that are coming through the system that came in as a diversity selection that were pushed through because it was you couldn't even consider dropping them because then they'd be screaming, racism and discrimination and this and that. So you keep putting these people through and you keep holding their hands. There comes the day when you got to turn them loose on society, and that's where it's going to get a little bit scary.
Yeah.
I go so far because I know it looks remarkable, but I'm 71 years old. And
It's all
God,
that plastic surgery, isn't it?
well, it does help. I got to admit, if I'd done the hair transplant, that would have been a lot better, but I just couldn't spring for those. But luckily, my wife and I are in excellent health. And so we're not really in the medical system yet, but the day is going to come. The day will come when I'm going to need an operation or my heart or whatever. And I'm going so far to say to myself, I'm not going to go to anybody who's under 40. If I go see a surgeon who's younger than 40 years of age, I'm going to vet them like there's no tomorrow to make sure that they're properly trained and have a track record and this and that, because I don't trust the education that these younger doctors are getting these days.
Was there ever a similar push towards equity, meaning the centralized intentional balancing of representation along sex lines? Because I'm sure, what's the distribution of male to female and the surgeon in that?
Oh, it's still heavily weighted to surgeons. I mean, surgery is very demanding, and women don't gravitate to the field of general surgery or whatnot. Plastic surgery is a little bit different. I mean, there's probably, I would say, I can't give you an exact number. I'll probably say it's probably close to 50-50. I will tell you that more than half the medical students in the country are female.
Okay.
So that particular ratio has flipped for sure. Something like 80% or more of OBGYNs are female. So, and pediatricians, many more female than male than pediatrics. So there are specialties that women tend to gravitate toward.
And was there ever any push towards equity, or was there some? I'm sure there's been some social engineering to make it more amenable to females.
It wasn't there when I was in training. It was never. If it was so under the radar that no one was aware. We were allowed to pick whatever we wanted to do. No one was pushed. No one said, well, you need to look at surgery because there's not enough women in surgery. There's nothing like that. Yeah. My class was very, very much weighted to white male. We had 120 some students in my medical school class. We probably had about 20 women, I would say. We had a couple of Asians, Chinese, let's see, a couple others from Japanese, a few blacks, not a large number of black students. No one looked at that in any way as being other than just the way things are. My daughter's medical school class, I was a graduate of 1978, and she's a graduate of 2018. I could not believe the diversity in her class. First off, it was 50% female. The number of Hispanic, Asian, Black students was dramatically greater than in my class. And I don't know if that was done because of selective admissions. I suspect there was probably some element of that. When you mention the word equity, people don't really, I think, appreciate what equity really, really means. And it's not equality, and it, you know, the word used to mean fairness. It was to be equitable was to be fair. Today, the word, as I hear it all the time, and as I believe most people that use it understand it, is that equity means that we're all going to have the same outcome. That, no matter what field we're in, that, everybody, all patients should have the same outcome. And they should get a good outcome from surgery. It should be the same across the board. If that is not happening, there's some form of discrimination going on against the group that is not having the good outcome.
Well, I mean, you could probably make a case that you could probably research more on like why these outcomes are different. And I guess one question would be, do Black people have different bodies than white people? And the understanding of bodies is based on white bodies, and Black bodies are different, and so they're not receiving. There's just an ignorance gap.
Well, there's this idea that race is a construct. It's a social construct. It doesn't really exist. I would say it does exist, and I think we ignored it at our peril. There are things that are by far and away, seen in certain groups that are not seen hardly at all in others. If you get a patient that had the Dupuytren's contracture in their hand, which is a very common problem that is seen in hand surgery, you can bet that patient probably has a Northern European background, because that's where people with that come from. If you get a patient that has thalassemia, which is a blood disorder, that can affect bleeding and things like that. Anemia, that individual is going to be from somewhere in the Mediterranean, Middle East Mediterranean area, because that's where thalassemia is most likely found. If you are you're not going to be testing a person of white European background for possible sickle cell anemia. That's a total waste of time, because that just is not seen in that population. So there are definitely physiological and genetic and so forth differences between the races. But one of the things that I think that is done in the name of DEI is to take people and categorize them so that Blacks are in one identity group, and that identity group is homogenous. So all Blacks they're this way. This is, if you're not this way, you're not Black. If you're a conservative politically, you can't be Black. A Black from Nigeria and a Black born in the USA are identical. But if you look at them and you see what how they do from the standpoint of economics and success and so forth, I mean, completely disparate outcomes in these individuals. So, you can't take, in medicine, you can't take a group of people because they have some immutable characteristic that they share, like being Black, and say, okay, because this is how we're going to handle that group. Okay, we're going to do it according to these algorithms, or according to this, we're going to go down this pie chart and so forth, and this is the way we're going to treat them. The thing about medicine that is really, really discouraging in terms of what's happened is that we've gone from the original intent of medicine, which is to treat the patient in front of you to the absolute best of your ability, to dealing with identity groups and trying to inject, social justice concepts. And we're supposed to take histories nowadays that have nothing to do with the medical problem and everything to do with how we identify people in society. Where are you on the intersectionality chart? Are you in the very, very oppressed category? Or are you in the very, very privileged category? And depending upon which categories you fit into, that's going to affect your medical care that you receive, all in the interests of diversity and equity and inclusion. And the interesting thing about the inclusion part is that if you don't subscribe to those things, you are excluded. I'm a perfect example.
Yeah.
Okay. And there's no inclusion for me in the ACS because I have disputed the prevailing narrative that the ACS is racist and that surgeons are racist. And because I don't believe that and I argue against it, I'm on the outside looking in that.
Well, I mean, obviously their ideas would totally stand up to scrutiny, and so they were just saving you time arguing about it. They've
Well,
already.
what's interesting about your that comment is just reminds me that I was suggesting back when they were inviting Ibram Kendi to be the keynote speaker that they bring in somebody else to provide a counterpoint to his positions and what he says. Um, Kendi commands $20,000 to $30,000 per hour for an appearance. He will not debate. He will not share the stage with anybody who disagrees with him, because if you disagree with him, you are a racist, and he will not debate a racist.
Uh,
So there is no willingness to have any kind of a civil discussion of all, different viewpoints, to let, for example, an audience listen to the arguments and come to a conclusion as to which they think, stands up best under scrutiny. He won't do that.
yeah.
And that's what's happened with me. No one can say that what I've said is wrong about my assertion that the ACS is not racist. They're not going to let me have that conversation. They're going to isolate me and silence me.
Well, on a medical level, has it ever been the case that there's been a treatment that has been for everybody at all times? Like there's just the human body was treated
Never.
as completely okay. So, and
I
has
can
there
tell
has it ever been
never.
tried, and what was the result of that
I
being
can
tried?
tell you from just a very recent example is the whole COVID um, policies in management. Okay, vaccination. Okay, we know for a fact that the COVID vaccines are not what they were purported to be. They're not nearly as effective. They don't last long. They don't prevent transmission. They don't prevent you from getting sick. There's a lot of signal and noise out there about potential problems. We know for sure that the COVID vaccines are connected to myocarditis in boys and young men. And healthy boys and young men should not receive COVID vaccines because the risk from COVID is close to zero and the risk from the vaccine is higher. And yet we have a policy, a top-down policy from the CDC that is an all one size fits all. And they recommend routine vaccination with COVID vaccines from 6 months and up. So I don't know if there may have been a COVID death somewhere in a young child that was otherwise healthy. But boy, that is a rare bird. I mean, statistically, the risk of a child getting sick from COVID is probably less than the risk of them getting a flu and getting really sick from the flu and
Yeah.
possibly dying from flu. But we have this top-down, one-size-fits-all policy about vaccination that completely ignores that there is a more than 1,000-fold risk between a child and a 70-year-old adult getting COVID, and yet we're treating them the exact same way.
Yeah. Yeah.
No, there is nothing. I don't care if it's cancer. I don't care if it's heart disease. There's nothing in medicine where a single treatment is going to be equally effective for all patients across the board. That's why you have to look at the patient in front of you and treat that individual as a unique individual.
Well, why would the professional organizations ignore that or overlook that? Are they just stupid or malicious, or is it inconvenient? Are they lazy?
There is an agenda. That's all I can say. There's an underlying agenda that supersedes the concept of individual Hippocratic medicine. There's some goal to which they are striving, I don't know, some utopian goal where everyone's going to be the same and get the same and do the same. Um, there's always this conversation about power, that sometimes the whole thing is about control and power. And, people that have this idea that we have the answers, the next step is, well, if we had the power, we could institute all these solutions because we have the answers. And so the goal could be simply to acquire as much power and ability, for example, to get people into the government that believe as you do, so that, when the time comes, you can force your ideology and your views on the rest of the population because you know what's best for them. We're seeing that. We're seeing that as it is right now. I mean, there's a push for things that don't make a lot of sense. Coming from the government immigration, the climate issue, oh gosh, the whole gender affirmation industry now
Yeah.
is pushing for doing things based on some type of a belief or ideology that borders on the religious. And if you start trying to look at it logically and rationally, you're not going to get very far because there is no logic or rationalization to it. Anthony Fauci famously said, if you criticize me, you're criticizing science because I represent science.
Oh,
And yet there's absolutely, oodles and scads of evidence and growing, mounting evidence that Fauci was so wrong on so many levels based on what he did as far as his policies for managing COVID. So
I
I
am the
don't have a good
science.
answer for you. People do inexplicable things, but
Yeah.
they say follow the money. Where's the money going? Power is a huge incentive. Sometimes it's just good intentions. People may have the best intentions, and yet they're wrong. I mean, if you take the vaccine policies as a good intention, they believe that vaccines are going to save lives, and yet if you start looking at the actual data and the numbers, you realize, well, yeah, they may be okay for maybe this population, but they're completely worthless for that population. In fact, they may be risky. But they say, no, vaccines are great. We need to keep the message simple. People can't handle complexity, so we're just going to put a single policy for everybody because that's the easiest way to do things. I think a lot of that is what happened during COVID.
Yeah. When you were talking about the protocol of getting disciplined by the ACS, yeah. Yes, ACS. This is why I have to ask about the acronyms multiple times because I forget them all. But I was trying to think, like, what would be the worst possible thing that a surgeon could do to be shunned by the or like officially, marked by the ACS, and I was thinking, well, probably like some sort of Frankensteinian, megalomaniacal attempt to just way beyond any sort of ethical parameters, and yet not quite illegal. But then he said, yeah, so that was the image in my head, and then he said, Fauci comes up, says, "Look at me, I am the science now." Like, wait. Like, that is a gross misrepresentation and overstep of a human being that should be a call for discipline.
You would think so. I would like to think so.
Yeah.
I will be flat out straight and say that I'm looking forward to the day that Fauci and others are indicted for crimes against humanity. I believe that with all my heart. That I think that he was complicit, along with others, in the development of the virus that became COVID. I think there's plenty of evidence that came out of the lab in China. We're never going to get to the bottom of it because the Chinese will never allow that. The fact that we even think the Chinese are going to be transparent is kind of laughable if it wasn't such a serious thing. So, there's been some pretty egregious things done out there without any accountability, without anybody being called on the carpet to answer for that. There's a lot of good doctors. I know some of them that were absolutely persecuted. I mean, just relentless attacks against their licenses, suspension of their licenses, threats against their licenses. And their crime was that they were treating their patients with things like ivermectin and hydroxychloroquine in the hopes of keeping them out of the hospital. A lot of this took place before there were even vaccines. So here we had no vaccines. And, a lot of doctors are scrambling to deal with this new virus and trying to get repurposed drugs. And yet, what they find themselves facing is a medical establishment, including the Board of Medicine in multiple states, that came at them as though they were criminals, as though they were killing or harming people. And they were doing the best they could. I mean, it's just, I've never seen anything like it. Then I'll tell you, I've been a doctor for, like I said, for 45 years. I wouldn't have done anything else with my life. I can't even imagine what it would have been like to do anything else. I've got lots of things I would like to do. I look forward to my retirement. I will be very grateful for what I've done, and I know I'm going to have some regrets about quitting. But I look at medicine today, and it is so broken. I mean, and I don't have all the answers. I mean, everything from insurance, and Obamacare was supposed to cure the problem of the uninsured. It's actually, I think, made it worse. I had to cancel an operation on a patient a couple of weeks ago, a Reconstruction case, because the hospital asked for her $6,000 deductible. I would have a hard time, writing a check for $6,000 for a deductible, and I can't imagine most people be able to do that. And so her surgery was canceled. And she supposedly has good insurance, but who has good insurance if you got to pay $6,000 before it kicks in? So, there's all these things, and the whole COVID thing was so discouraging to me. I mean, when I wasn't working, I was online, I was writing comments and blogs, and my family almost had to have an intervention to get me off social media for a while, because I was so enraged by what was happening.
Yeah.
And then we have medicine is debating, whether there's more than two sexes. I mean, come on. I mean, we're having this actual discussion whether there's more than two sexes or not. And the idea that you can do anything to someone and you're going to turn them into the opposite sex, that I don't care how much hormones they give them, I don't know what surgery you do, that you're going to convert them to a Frankensteinian version of a human being. And there's lots of studies that come out of places like Sweden and Denmark that suggest that the mental issues, that are up there, that lead to these things, are not necessarily resolved by these transitions. Countries that are very, very accepting of trans people have suicide rates of 20% and above for people that have transitioned. It's crazy. Medicine has gone completely off the rails. I'm just trying to do my little bit. I'm pushing against the ACS, because this is where the issue came to rest in my particular case. I'm getting involved in some other issues gradually as well. As a plastic surgeon, I know a lot about what's involved in trying to do some of these transitional surgeries. I do mastectomies. I do reconstruct breasts. I've been involved in perineal reconstruction with flaps, so I understand how we do these things. And I'm telling you, not that easy to build a penis or vagina. I mean, to think that you can do that and you're going to have a perfectly working, part of the body that you go on with your life and ignore, that's not the reality. You're going to have potentially all sorts of problems with that. So there's a lot of things to be discouraged about in medicine, and I'm hoping that I can do my little bit to help turn that around.
Well, is there any sort of protocol for keeping your professional organization accountable for the decisions? I mean,
no, as far as I know, there is not. I mean, I can only speak for the ACS because that's where I'm most familiar. These decisions that I was pushing back against were made pretty much behind closed doors in the leadership of the ACS. They're never brought to the general membership for discussion or a vote. They were simply announced that this is what we're going to do. The task force announced that we're going to do these things, and boom, 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 they were done. And they're there. So they were basically accomplished. They recently came out with a toolkit. The ACS just launched their DEI toolkit, which I wrote about and against in a National Review article. Oh my God, to read this toolkit again, it's like, what the heck are we talking about? They use as references things like articles that say that Black babies do better if the Black obstetrician is Black. I mean, if the obstetrician is Black. If the mother's Black, they need a Black obstetrician because the survival rate for Black babies is higher with Black obstetricians. Well,
is that true?
No, it's absolutely not true. I mean, if that study has been taken apart repeatedly. And in fact, one very respected critic of studies, who's a data nerd, went through that study and said this study is catastrophically flawed. It is not remotely a study that should be used to make this conclusion. What happened is they take a conclusion, like, surgeons are racist, and they start to design studies or interpret studies in a way that will support that conclusion. Instead of, taking the data and seeing where it goes, they're directing the data in ways that will provide for the outcome that they're seeking. And this is in their DEI toolkit, which is being promoted to surgeons as a way to implement DEI in their practices.
Yeah. Do you expect like a rash of Rachel Dolezal surgeons to like fill in to save the black babies? Like you just show up in blackface? Do you think that would work?
I don't know if I want to answer that question.
Okay, no, that was that bait. Did I just bait you? Well,
Yeah,
it's
it's
like
but the
Lysenkoism.
idea, yeah, the whole idea that you have to have a segregated medical uh, field where, black people are treated by black surgeons and Hispanics by Hispanic surgeons and Asians by Asian surgeons. That's insanity. I mean, that's taking us back to even before Jim Crow. I mean, basically, we
Yeah.
are returning to segregation. We already have segregated dormitories in colleges. We have segregated commencement ceremonies. We are now, I know this is a medical school because I've read this in various places that medical schools are now separating medical students into different identity groups to to discuss issues separately. The black group to discuss the black oppression and victimization.
Yeah.
The white students are there to discuss their white privilege and how they can deal with their inherent whiteness and so forth. And this is all happening right in front of us today. And it's like this cancer that's taken over the country, and we've been kind of blind to it until it became, something we could no longer ignore. And now we're fighting against this overwhelming avalanche of ideology and trying to push that back. And it would have been so much easier if we'd done this, 20 or 30 years ago. But now we're under the gun to try to take back
Yeah.
some of these institutions.
Well, you said yourself that you didn't see it decades ago.
No, I was oblivious. I mean,
Yeah.
the problem with doctors, I'm as guilty as anybody else, is it's a very demanding profession. I don't care what specialty you're in. It demands a lot of your time. Not only do you have patient care time, you've got all the continuing education, you got running a small business, if you will. There's, you have a family. Most doctors have a family. Obviously, you want a little downtime for yourself. And to find discretionary time to be an activist, to stay on top of all these things, they've piled stuff on over the years, and we've kind of been that frog sitting in the pan.
Yeah.
And they've been turning up the heat slowly until finally, I think finally some frogs are starting to jump out of the pan. A lot of frogs sit in there and just boil to death. And that's, you get the highest burnout rates we've ever seen among physicians today.
Really.
A lot of physicians are not waiting till their anticipated retirement. They're leaving sooner. I never anticipated retiring. I thought I'd retire when I was too old to practice anymore because I love what I do. And I still think I'm somewhat in my prime. But I'll be honest with you, I'm tired. I love surgery more than ever, and I'm going to miss it like crazy. I'm tired of what I have to do to get to the operating room. All the bureaucratic red tape that I have to abide by and deal with. Regulations, insurance. I mean, I'm battling insurance constantly because they make the decision. They say, well, don't let us affect your treatment of the patient. You just do what's best for the patient. Well, that's all well and good to say, except that the patient's going to incur a bill from the hospital that they're not going to be able to afford to pay, and the hospital's going to put a lien on their home, for example. So I'm tired of that. I'm tired of all this stuff, and I can understand the whole issue of burnout. I mean, I don't feel burned
Yeah.
out, but I'm tired and frustrated of fighting a system that is becoming more and more antagonistic to the practice of traditional medicine.
Yeah, this is some sort of late stage empire stuff. Just like education's in the same boat. Just primary education teachers are just getting burned out quicker and quicker and quicker. And, that.
Yep.
So,
A couple of years ago, we crossed the line. For the first time, there were more doctors employed by corporations and big medical centers than were in independent practice. I'm still an independent practitioner. My partner and I have our own practice. We're not part of any group. But that line was crossed to where most doctors are now employees. And that brings up a whole different dynamic. And the paradigm there is produce, produce, produce. I mean, you're under the gun to see enough patients to justify whatever salary they're paying you. You've got to meet all these metrics. They have these, you've heard of press gaining scores. Are you familiar with those?
no.
A press gaining score is a way of assessing patient satisfaction. So they go to patients and say, how was your care? Was Dr. Smith nice to you? Was the food in the hospital good? with a nurse, a kind nurse, and so forth. And so you have these Press-Ganey scores, and they've shown that they have nothing to do with level of patient care. But doctors that are employed by organizations are under the gun to get these great Press-Ganey scores. So if you're a doctor that says to the patient, well, you got to quit smoking and lose weight and do some exercise, well, that patient's not going to like you very much because they want a pill. They want an operation or a pill or something that's going to fix the problem. And so the whole idea is turned upside down about, what a physician can and can't do. You can't tell someone to lose weight because now you're fat shaming them, you're body shaming them. So to tell them that, your body mass index is 40, that's morbid obesity, and your risk of diabetes and hypertension and arthritis and this and that are higher, you need to lose weight. Now you can't do that because, we have to make sure that we're encouraging their body positivity. Then it's nuts. Medicine has gone nuts. I say it, and I say that in complete seriousness, and literally it's gone crazy.
Well, at least we can all move to Canada. They're doing really good up there, right?
They're doing great up there. I hear Costa Rica is really nice, though. The weather is better, and the government's friendlier.
Costa Rica?
They have good surfing and diving, from what I hear.
Okay, well, I wouldn't mind going there. Is that where you guys are going to head? I mean, you're in Florida. Where do you go to retire? New York City?
I basically stay here. We're going to keep our house, and our kids want us to join them in the Carolinas, but we're not ready to leave Florida yet.
Yeah.
One of the few staying states in the union at the present time.
Yeah. Did you grow up there, or you just ended up there for college?
I was all over the place. I was born in Colombia, South America. I grew up half in Brazil, half in the U.S. Miami is my hometown. So when I think of my hometown, it's Miami.
Wow. And so you are now, it sounds like you're doing more and more articles. Do you have a presence online, or is it just every now and then a random essay?
It's largely that. I'm growing. Nowadays you really have to have a presence online if you want to get anything done. So I do have a Substack. It's Richard T. Bosshardt, MD, Substack.com that I have. I had a blog site called Beyond Plastic MD, which I'm slowly phasing out and moving to my Substack. Substack, if you're familiar with it, is really geared to writers, which is where I kind of see myself going. I've got a book I've written. I've written a book on plastic surgery that I'm working on trying to figure out how best to get it out there. It's very hard to be published if you're unknown. And so I may go the self-publishing route, or there are people that are putting books on Substack.
Is it a technical manual, or?
Nope. It's kind of a summary of what's happened over the course of how the first book is actually a two-part book. There's one part that is what is a plastic surgeon? How are we trained? I mean, people, like you said in the beginning, they think we're nip tuck specialists, but if they look at what I did in training, they're going to be amazed, because I was blown away by how broad the field is and how much, we work from the head to the toe. I mean, literally, toe reconstruction, head reconstruction. That's all part of the specialty. So the book and the Substack, and I'm getting a low battery. I just realized I got a low battery thing here. So I probably need to plug in here before this thing shuts off. Can you give me 1 second to plug in?
Yeah, sure. And then plug your work.
1 second.
We're in the plug part of the show.
All right. These are the little things that, when you have some experience with these sorts of venues, that you learn all the important things, like make sure you check your battery before you start.
Yeah.
I thought it was pretty good when I started.
Yeah.
What were you asking?
Just about your work. And you're explaining your book. It's a two-parter. One is about the...
Yeah, it's called what is it? The title is gone. I haven't settled on my title totally. The Making of a Plastic Surgeon. 2 years in the crucible, learning the art and science, because it really was a crucible. It was the hardest thing I've ever done, was my 2 years of training. The guy that trained me was an absolute brilliant genius of a man. But oh my God, was he hard to get along with and intimidating.
Oh, really?
So the Substack and the book are the two things I'm working on right now, and trying to get I post on Facebook. I haven't done much with others. I post on Twitter, now X. I hate that. You have to say that all the time. No one can call it X. They always say, X that used to be Twitter. I don't know why they had to change the stupid name, but I'm on X a little bit, not a lot. It tends to be it's not my idea of a great venue, place to be putting stuff. That's pretty much it. And then, I've gotten a fair amount of exposure on things like your podcast. I don't know how wide a net you cast, but it's going to be definitely wider than my own net that I'm casting right now, to be honest. Yeah. I'm very fortunate to have been published in some decent outlets that have a pretty good readership. I think that the Washington Examiner goes out to 100,000 people. And of course, there's that ripple effect. Those 100,000 are going to pass this on. Hey, you got to read this, that gets out there. So I made it onto Fox a couple of times. Wall Street Journal brought me to the attention of Tucker Carlson. So he had me on his show way too briefly. And then my National Review article got me again the attention of Fox. And that ended up being kind of people said they saw it. I can't ever find it. I've never seen my interview on, I think it was the Jesse Waters show, but people said they've seen it. So yeah, I'm trying to get the word out. I'm trying to make as much noise as I can. I want to be that little annoying buzzing fly around the head of the elephant, which is the ACS.
Yeah.
And if I have to state a goal, my goal is to stimulate enough interest and hopefully enough outrage between what was done to me and what the ACS is doing to surgery that my fellow surgeons will sit up and take notice. And maybe there'll be enough pushback that the ACS will rethink the direction they're going in. And my pie in the sky goal would be to initiate I wouldn't call it a rebellion, but I would say a turnover of the leadership to get rid of these people that have installed these initiatives, get them out of there and get those initiatives out of the ACS as well. I can't think of a thing you can say worse than to say that a surgeon's racist. Because, if you go to the ER, you walk in cold, you don't know a person, they don't know you. This is probably the worst thing that's ever happened to them in their life. They're in pain, they're injured, and they're scared. And you walk in, and if it's a black patient, you're this white guy. Do you really want that surgeon? that patient thinking, oh my God, this is a white guy. I don't have any choice. I've got to deal. Is he going to give me the best care? And I'm thinking, okay, I'm going to do the best I can for this guy, but what if things don't go well? If he doesn't have a good result, is it going to be, come back on me because I was racist? What if he doesn't follow my instructions because he doesn't trust me?
Yeah.
If I tell, the effect of that is so toxic, so poisonous to medicine and surgery that for surgeons, for leaders in the surgical field to be saying things like this, you got to push back against it. You can't just sit back and let them do this.
It breaks the chain of trust, and trust is really important in your field.
Oh, it's incredibly important. There's probably little that's more important than trust. Competence, obviously, you want a competent surgeon. I think I took Tucker Carlson by surprise because I asked him what he looks for. What's important for him in seeking a surgeon, and you could tell he wasn't expecting a question, and maybe why he cut me short. But he said competence, and I said, yeah, but how about trust? Isn't trust important? Don't you have to trust your surgeon? To trust them, you have to believe they're competent. Hopefully that belief is not going to be misplaced. It's going to be justified. And usually it is. Surgeons are usually know what they're doing especially if they've been at it for a while and they maintain the practice. You tend to weed out the really bad apples pretty quickly. But then you have the surgeons that are kind of so-so. And I work with them. I work with surgeons that I would never go to them myself as a patient. But I've watched them work and say, oh my God, but patients survive. They do okay. They may not get the best scar, or they may have this complication or that complication. But, the human body is pretty resilient and can survive an amazing amount of abuse, to be honest. People do things to the body that are just incredible, and they still. Keith Richards, I've got tickets to go see the Rolling Stones in June.
Yeah.
My wife and I are not even fans. We can't not go. And I keep thinking Keith Richards died, years ago, but no one ever told him. And, oh my God! Truly, the guy is unbelievable. The abuse his body's been through, and he's still walking and talking. It's so people can survive bad surgery, bad surgeons, but they shouldn't have to any more than the minimum,
Yeah. Yeah.
possible.
Yeah. Well, Dr. Rick, thank you very much for your time and sharing this story. And I'm sorry you don't have a whole bunch of nose facts to share for me, but you gave it a good shot. Thanks for exposing me to thinking about this part of life. Like I've never had plastic surgery, so I've never really thought about it. So it's good to like kind of get down in the nitty gritty of
Well,
that.
I don't do a lot of men. Men don't make good patients, to be honest with you.
Oh, really? Why?
Oh my gosh, I'm gonna get in trouble for saying this, but men are the most difficult patients. They have very poor pain tolerance. Women have a whole different perspective on pain. I
Huh.
think childbirth gives them that. Okay, so you have that aspect of it. And there's and I say this not everybody, but there's a level of narcissism in men seeking cosmetic surgery that you don't see in women.
Huh.
You got to be really careful. One of the really, and this is true. One of the patients you have to be most careful about are men seeking rhinoplasties. There's a high level of narcissism and other
Perfectionism and
pathologies that are seen in men who are seeking to have a rhinoplasty done, which you don't really see that much in women.
and would do you think that translates to men seeking vaginoplasties? Probably.
No, I don't think so. I think that's a whole different pathology.
Okay. All right. Cool. I wonder what's about the man who's uncomfortable with his own nose. That's a
Yeah,
condition.
that's a interesting problem, and we're dealing with it right now, for sure in this country. The push to turn men into women and women into men has not abated. It's still out there.
Yeah. Yeah. Well, thank you very much. Very fascinating conversation. Thanks for joining my wife too. It's great to kind
Oh,
of.
delightful to meet you both. Thank you for having me come on. If you like, I'll be better prepared if you ever ask me back on to give you some actual data and statistics. I'm not really a numbers person.
Yeah. Yeah.
That's not been my thing. I wasn't the resident in training that when they would ask me a question, I would rattle off the article and
Yeah.
the volume and the author of the article and all that sort of thing, like some of my colleagues did.
Yeah.
But I made it through 45 years of medicine and done, I think, more good than bad. So I think I've been okay.
Oh, great. No, this conversation was more good than bad. I never demand an eidetic memory from my guests. So
I appreciate that. Thank you. That makes me a lot more comfortable.
yeah.
I
Yeah.
wish I'd known that at the beginning. I wouldn't have been so nervous.
Oh, that's fine. That's fine. Fine. Well, thank you very much, Rick.
This was fun. Thank you, Ben. I hope that this will not be our last communication, even if it's only off camera. But and my regards to your lovely wife.
Absolutely. Absolutely.